This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
In this video, I'll be demonstrating the transconjunctival way of doing manual smudge cataract surgery in this video. Now, she's a 60-year-old lady who has this white intumescent cataract, and we have scheduled her for manual smudge cataract surgeries. It's in one of our charitable centers. The surgery is being done under a peripheral bar block. So I've not used any superrectus suture. I'm sitting temporally. And this is a temporal MSICS which is being done. So I need to begin by doing a transconjunctival scleral incision, and to aid that I need to fixate the globe well. A tooth forceps is used to fixate the globe by holding at the nasal limbus and turning the globe away from me, as the first incision, which is about 1.5 millimeter from the limbus, is done through the conjunctiva onto the sclera. So we expect some amount of bleeding to happen. The first incision would not be deep enough, so I'm just trying to deepen the incision, ensuring that the incision has really gone onto the sclera. And once it is done, it's time to do the tunneling. So the most important step when you're trying to do a scleral tunnel in this eye would be to fixate the globe well. Now, because there's no traction suture, this like the superior rectus, so we need to stabilize the globe well, and so I'm using a pair of teeth limbs forceps to stabilize the globe by holding it at the conjunctival tenon complex. It's held exactly at the limbus. The why limbus? Because this is where the attachment between the tenon and the conjunctiva is very strong, and we get a good hold. So getting a good grip by holding the conjunctiva right at the limbus is a key element to achieve stable globe when trying to do the tunneling. The blade is introduced initially, and how to assess the depth of the tunnel is to ensure that the blade should be just seen through the sclera. So I prefer first to go directly through the sclera into the cornea and then extend the tunnel laterally on either side. So as we are going on the lateral side, it's mandatory that we need to tilt the blade just a bit to respect the changing counter of the globe, because as we go towards the edges, the globe's counter changes, and we need to change the count of the blade which we are dissecting to match with that changing count of the globe. So the tunnel is done. The internal part of the incision probably would be measuring 7 millimeter. A 2 millimeter side port incision is done using a keratome. The capsule is stained under the air bubble. Viscoelastic is injected into the antechamber to pressurize it. I prefer to make the main entry now itself. So viscoelastic is injected in the tunnel to delineate the inner lip, and then using this sharp keratome, the blade is introduced, reaches the most inner part of the tunnel, which we can see this demarcation line, and then it enters the antechamber. The lateral extension is done on either side to ensure that we have an adequate sized opening, and I always prefer to have the inner lip running parallel to the limbus. So since it's an intumescent white cataract, I would always prefer to use a forceps to perform the rhexis. The flap is raised, and then an adequately sized capsular opening, which is about 5.5 millimeter, is performed. There's no hydrodissection done, no need to do that, as I don't expect any corticocapsular adhesions. This is a mature intumescent cataract. I prefer to mobilize the nucleus out of the bag by using 2 Sinskey hooks. My right side instrument pushes the nucleus to the right side, exposing the equator of the nucleus on the left side. The second instrument on my left hand goes under the equator of the lens, and then using these 2 instruments, the nucleus is gently wheeled out of the bag. OVD is placed in front and behind the nucleus, and I would prefer to extract the nucleus out using the phaco sandwich technique. The dialer is introduced first, and it just traverses onto the surface of the nucleus as the victus is being introduced under the lens. Now the nucleus is compressed in between the dialer and the victus, and this is what we call as a sandwich, and then we can negotiate the nucleus out of the eye. I'm using viscoelastic to burp out all the loose lens matter in the anterior chamber. There is a little bit of an epinucleus and cortex still in the back. I need to deal with it. So I'm going to use the Simcoe cannula to remove this lens matter. Some of the remaining loose lens matter I would like to remove it after implanting the lens. The pupil is coming down a little bit, so I'm using viscoelastic, which also helps us to dilate the pupil a bit. Space is created within the bag, and the planned PMMA lens is gently negotiated into the bag. The distal haptic is first introduced into the bag and then followed by the optic. At this stage, I realized that the distal haptic would not have probably gone into the bag. I'm not so sure. I need to recheck it. The proximal haptic is now then being dialed into the bag. The proximal haptic has gone into the bag. It's very clear now, but I need to just verify that whether the other part of the lens is inside the bag. The pupil has come down, making visualization a little bit of a challenge. I'm just introducing a little bit of phenocane to dilate the pupil. Chamber is again filled with OVD and the visualization is better. I can see that the bag is decentered a bit, so that confirms that the remaining lens is out of the bag. So I was certain that the other part of the haptic was in the sulcus, so it is gently dialed into the bag. The remaining lens matter which has gone under the lens is irrigated out, as is the OVD, and then time to remove the OVD in front of the lens. So the advantage of doing this transconjunctival surgery, when we do the conjunctival flap and then again close it using cautery, there is a little bit of an conjunctival elevation. There is always a risk of Dellen formation, and even cosmetically it's not very appealing. So doing a transconjunctival surgery, especially when doing temporal, is really great. It has got a learning curve to begin with, and once you get the hang of it, it's actually pretty good. We may have a little bit of redness in the exposed optic in the area because of the subconch hemorrhage, but over a period of time, the incision blends very well, and we hardly see any sort of a scar later on. And of course, the biggest advantage of doing a temporal surgery is we have very minimal surgical induced astigmatism, and the results are comparable with that of a phacoemulsification. So that was it. Thank you for watching, and hope you found this helpful.